Hi guys, welcome to the very first video of cardiology where I'll be describing heart sounds before you. I'll be using a couple of fancy terms like pericardial shudder, pericardial knock, and then even tumor plop sound. And I'll be also explaining to you how to time these heart sounds, whether they are systolic, whether they are diastolic with a hand-drawn line diagram. And what you can notice in the animation here is that in the exam, they could be giving you a phonocardiogram, they could be giving you a combination of ECG, JVP and heart sounds all rolled into a single MCQ. But for you to be able to interpret that, you need to listen to some background information that I'll be stating before you. So what I'm going to do next is draw some line diagrams before you representing the cardiac activity. In the first diagram, I am going to show you atrial systole. So at the movement, you can see that the tricuspid valve on the right and the mitral valve on the left is open, and there's gonna be blood coming into the ventricles of the patient. In fact, atria contribute approximately 30% of filling of blood into the ventricles. And why that is important to know is because in the later part of the discussion, we're gonna talk about atrial fibrillation, atrial flutter. You can understand from the current representation that movement atrial fibrillation will start because the atria not gonna be doing their job properly. 30% drop in blood pressure will be anticipated right away. Now, once the atria have done their job properly, the next event that will be occurring in this patient would be the closure of the tricuspid and the mitral valves. So I'm just gonna sketch it here. This is tricuspid valve and the mitral valves that's gonna be closing, and therefore in the exam you have to understand that first heart sound is always gonna be at the end of atrial systole, because everything that I will say here will either be end of a particular event or it will be a start of a particular event. And at this moment you might be saying, sir, what's the big deal about it? But when they try to put this data on a loop on a continuous basis where multiple aspects are asked simultaneously, people are not able to strike the question relatively, I would say, without any error per se. And obviously you understand precision is important and speed is also important in the exam. So I've just highlighted that now the ventricles are beginning to contract, but at the moment the pressure is definitely not sufficient to open either the aortic and the pulmonic valves. In fact, the second diagram that I'm making before you at the moment is a condition where no blood is coming in and no blood is going out. So I'm going to call it a isovolumetric contraction. And at this point of time, the ventricles are, I would say, gradually increasing the pressure. And just few milliseconds later, let us see what happens. In the subsequent diagram, I'm going to represent the opening of the aortic and the pulmonic valves. And also, because of the pressure, I have also shown a slight bulge of the tricuspid and the mitral valves. I have exaggerated it just on a representation, on the representative purpose. The bulge here, I mean, obviously it's only few millimeter bulge that would be occurring in reality, but once the pressure builds up here, this is going to cause a opening of the aortic and the pulmonic valves. So in the third line diagram that I've drawn before you, you can very well see that right after S1 you're gonna get another event which is not S2. I agree, after S1 you obviously have a S2, but because they're going to ask you information even from physiology, so what you can see at the moment is that when 80 ml blood is going to rush into the aorta, 80 ml blood into the pulmonary artery, the valves which are opening here will be responsible for production of a sound that is called as a ejection click. In subsequent discussions, I'm going to use the word loud ejection click. Now, loud ejection click is something that you're going to be encountering in valvular aortic stenosis. As a physician, I can say with my stethoscope, I can appreciate a S1, I can appreciate a loud ejection click, but not a normal ejection click. But in the exam, because they love to ask about basic physiology also, so that's why I'm speaking about it at the moment. You will also notice me talking about opening snap. You see, in clinical practice, what we are able to appreciate is a loud opening snap in mitral stenosis, not a routine opening snap, but this is background information and baseline information from, I would say, first and second year. So we're just quickly practicing it here. And at this moment, I also want to say that exact equal amount of blood is going to go out from the left and the right ventricle at the same time. If there's a lack of coordination, like in bundle branch block, or let us say, to make it easier, let me say a person has suffered from a MI and therefore the output from the left ventricle is reduced by only 1 ml. I'm not making it very dramatic. I'm saying only 1 ml less blood is going out of the heart. If 1 ml will go out less, then 1 ml extra will be present in the left ventricle. You see, after all, the left ventricle is having a fixed amount of blood, out of which 80 is going out. If less will go out, the amount remaining behind in the ventricles will be more. That would be 1 ml extra per beat. If the heart is beating 60 times per minute, the amount of blood which will be extra in the left ventricle will be 60 ml. In 10 minutes, it will be 600 ml. Do you think that 600 ml blood can accumulate in left ventricle? No, because there is no space present. So where will it accumulate? In the lungs, and this patient will develop very severe pulmonary edema. I just wanted to prove to you that if even 1 ml difference is there between the output of the left and the right ventricle, a person can die within as little as 10 minutes. So in MI or in any patient who's, let me say, having a viral myocarditis, let us say COVID-19 myocarditis has occurred, the cardiac output will decrease even more substantially and the patient can die much faster. So anyway, the treatment for acute pulmonary edema is discussed separately, but I just wanted to tell you how precise our cardiac hemodynamics is, that even a few ml difference can be contributing to a high chances of mortality. Now let's look at the fourth line diagram that I'm making before you, and I want you to compare this with the previous one. First, I have shown the tricuspid valve has come back to its original position, mitral valve has already come back to its original position, and now the aortic and the pulmonic valves which were previously open will now close. I have currently in the red wavy line shown before you the closure of the aortic and the pulmonic valves, which is going to be responsible for the second heart sound. So you can very well notice from this representation that traditionally we read about the lub-dub heart sound, that is S1, S2. But if he says what is present between S1 and S2, it's going to be an ejection click, which is characterized by aortic and pulmonic valve opening. And now even the venous filling of the atria would be starting. So from the physiology perspective, I can also put up the fact here that ventricular systole, once it ends, at the end of ventricular systole, I'm having a presence of second heart sound, and now the heart is beginning to relax. So this would be called as isovolumetric relaxation. And let us now see with the fifth and last line diagram, what's going to happen to this blood that's entering into the atria. In the fourth diagram that I made before you, you could see that the blood was not given permission to go into the ventricles thanks to the tricuspid and the mitral valves which were holding their position. But now both of these chaps will open. So what I have done here is I have once again shown that the tricuspid and the mitral valves are opening. You see the first diagram that I drew before you was also having mitral and tricuspid valve opening. So I do get a lot of queries, sir. What's the difference between the two? The difference between the first diagram and the fifth diagram, the fifth one is the one that I'm marking at the moment. The difference between the two is that in the fifth one, it's gonna be a free flow of blood directly into the ventricles of the patient. You see in the first diagram, atria was contributing to approximately 30% filling. Now what I'm saying is that this particular stage of rapid ventricular filling will contribute to the remaining 70%. You can very well see that the filling of blood in the heart occurs both in the phase of atrial systole, obviously during ventricular diastole as well. And you can also see, I can just zoom into this image, which valves are opening at the moment. The valves which are opening at the moment are the mitral and the tricuspid valves. So the opening of both of these valves is what is referred to as a opening snap. Loud opening snap is obviously what you can hear with the stethoscope. That would be a mitral stenosis patient. But opening snap anyway is a normal physiological event, and it's characterized by mitral and tricuspid valve opening. And if he says, when are you gonna be having an opening snap, your answer would be, it would be at the end of isovolumetric relaxation. I reiterate the statement, every event that I've described here before you, whether it's going to be S1, whether it's going to be ejection click, S2 or opening snap, they are occurring either during a phase or at the end of a particular activity. So you just need to get this orientation right, that S1 occurs at the end of atrial systole. Ejection click would be occurring during ventricular systole, but the moment ventricular systole is over, you would be having a S2, and subsequent to that, the rapid ventricular filling contributes to opening snap. And now let us represent this on a single line diagram. So this is what I'm saying. You would be able to auscultate S1, S2, the lub and the dub heart sounds. The duration of systole is obviously lesser as compared to that of diastole, because the heart will anyway be requiring some time to get filled with blood. Now period between S1 and S2 is called as systole. Why? Because right after S1 I taught you there's gonna be an ejection click. If you just focus on the English word ejection, it means that there's gonna be blood going out of the heart. So what I've just represented here is systole per se, and the moment the systole will be ending, that is precisely the time when the aortic valve of the patient and then the pulmonic valve of the patient would be closing. I want to tell you that aortic and pulmonic valves do not close together at the same time. First aortic valve closes, then pulmonic valve closes, and there's a gap of approximately 30 milliseconds between the aortic and the pulmonic valve closure. I also want to highlight a physiology concept here, which is that the moment the systole will end, listen to these words carefully, the moment the systole will end, that means the blood has gone out of the heart, there will be a period where the systole has ended and the aortic valve will close. This very small green representation that I made before you is the period which is taught in physiology as protodiastole. Meaning of the word protodiastole is left ventricle has done its job, the right ventricle has done its job. Now it is the time for the aortic and the pulmonic valves to close, because right at the end, right, the aortic and the pulmonic valves will close. So it will take few milliseconds. So I said two concepts. One, I said first aortic will close, then pulmonic will close. Between them gap is 30 milliseconds, but I added additional point that the moment the systole ends, it's gonna take some time for even the valve to complete its exertion. So the green representation that I made before you at the moment is primarily for what you study in physiology also, that is a protodiastole, after which there would be a presence of an opening snap. And this particular period that I'm now marking before you between right A2 and the opening snap, right from A2 to opening snap, is what you refer as isovolumetric relaxation. So I'll definitely be putting data with respect to the star mark in a while, because it's too small. I thought it will become very clumsy and the font size will be relatively smaller, but what I've shown at the moment is isovolumetric relaxation. Let us see what happens subsequently. You would be having is the phase of rapid ventricular filling, and this is gonna be contributing to approximately 70% of filling of blood in the heart of the patient. Now once the rapid ventricular filling has ended, there is a momentary period, I'm saying the word momentary period, when you might be having heart literally stationary, when there is nothing happening. So in physiology you would have read about another term, diastasis. This is itself a multiple choice question, that during which phase of cardiac activity the heart would literally be standstill. Obviously, you know, it's in a relative term. Why? Because heart never stops beating. Heart is either gonna be contracting or it's gonna be receiving blood, but the least cardiac motion, remember my words, least cardiac motion is gonna be present during the phase of diastasis. And right towards the end, what I'm gonna do here is represent atrial systole before you. So if you look at the representation, what I've done is I have divided the diastole into total of 5 components. The first one, which I'm marking now before you, is called as protodiastole. If they ask you protodiastole is gonna start from, your answer is end of systole and ends at aortic valve closure. Only aortic valve closure. Pulmonic valve closure will occur even after it, and the time lag between these two also will be discussed in detail subsequently, but it's still my job to highlight that the duration here is approximately 30 milliseconds and it varies with respiration also. So the diastole component has been divided into 5 components: protodiastole, IV or rapid ventricular filling, and diastasis, and you are able to appreciate normal heart sounds here. Over and above this, I will also use this opportunity to mention regarding a couple of abnormal heart sounds. That's going to be third heart sound and subsequently the fourth heart sound. You see, in the exam, they simply put up a question: which heart sound is present right before S1? If you look at the diagrammatic representation, you obviously can answer which heart sound is present right before S1. You can see it's gonna be fourth heart sound. Obviously, fourth heart sound is gonna be heard in pathological states. You will notice that fourth heart sound is also called as atrial gallop rhythm. One of the reasons why you will be having fourth heart sound would be long-standing hypertension. Why? Because in long-standing hypertension, patient would be having left ventricular hypertrophy. Left ventricular hypertrophy will cause a left atrial hypertrophy. And when I say the word left atrial hypertrophy, the atria will generate more kick. It will generate more power, and because it is generating more power, it will create turbulence, and this turbulence would be heard in the heart of a person with long-standing hypertension. That is referred to as S4, whereas S3 is heard in the phase of rapid ventricular filling, and this is also referred as ventricular gallop rhythm. In the subsequent discussion, I'll also tell you conditions where we get, how to work out a table. Like they give you all except MCQ, third heart sound. There's a table in the textbook with respect to conditions having third heart sound, conditions having fourth heart sound. So I will give you hacks and solutions to how are you going to work out whether it's going to be third or whether it's going to be fourth heart sound. But at the moment, what I request you to is just to get the orientation right. And I also want you to remember that all the data that I have shown in this slide diagram in color black is relatively a high pitch heart sound. The high pitch heart sounds are heard with help of the bigger side of the stethoscope, that is the diaphragm. In contrast, the one that I've shown in color green, that is third heart sound and the fourth heart sound, these are low pitch heart sounds which are going to be heard with the smaller side of your stethoscope, that's going to be the bell. In fact, there are three important low pitch heart sounds which are to be remembered. Two have already been told to you and the third one I'll be telling you in the subsequent slide, but you can still make an effort to remember here. Third heart sound, fourth heart sound and tumor plug sound. What is a tumor plug sound? Well, obviously it's telling you there's a cardiac tumor that we're going to discuss here. But before I draw the line diagram for it, I want to sensitize you to the fact that all heart sounds will be answered by you as high pitch except three: third heart sound, fourth heart sound and tumor plug sound. Listen to my next words with lot of care. Even the murmur of mitral stenosis is a low pitch heart sound. The murmur topic is discussed separately. I am writing that the murmur of mitral stenosis is also a low pitch murmur per se, but I'm putting it in bracket. Why I'm putting it in bracket is just to sensitize you to the fact that you see heart sound and murmurs are not the same. You see, by English, obviously by English word, murmur is also a sound. Murmur is also a sound. But technically speaking, the meaning of the word murmur would be that there would be a shunting of blood from a high pressure circuit to a low pressure circuit. So this I'm just incorporating to sensitize you to the fact that mitral stenosis murmur is also a low pitch murmur. But the bottom line is when he uses the word heart sounds, then it's the top three that have to be basically remembered. That is S3, S4 and a tumor plug sound. And once you get this orientation right, at least I would say 50% of the job is done from the perspective of what comes before and what comes later. Now, what I mean by tumor plug sound here is the fact that this person is having an atrial myxoma. This atrial myxoma is usually a pedunculated tumor, so I've just exaggerated it a bit, but this tumor has a stalk, STLK stalk, by which it keeps on being suspended in the left atria per se. And when you're gonna be having filling of blood in the atria, like this is the venous return that is happening. So on the right hand side, the blood will be smoothly able to enter into the right ventricle. But on the left hand side, if I just zoom it in, what I'm trying to say here is that the moment the blood will hit this tumor will swing like a pendulum. And this tumor will go and it will strike the mitral valve leaflet. And the sound which is produced due to this tumor impacting on the mitral valve leaflet is what is technically called as tumor plug sound. You can very well see from the line diagram that I made before you that tumor plug sound, which is the low pitch heart sound, will be a diastolic finding. Why? Primarily because you can see the blood is getting filled in the heart per se, though the amount of blood that will be entering into the left ventricle of the patient will obviously be lesser. As compared to the contralateral side, you can see that the amount of blood coming here will be dependent on the size of the tumor. If I just increase the size of the tumor, hypothetically speaking, let me make this tumor as big as a golf ball. If I make this tumor relatively bigger, you can very well see it will cause a substantial amount of obstruction of the mitral valve orifice, and therefore he can simply say that this disease will behave like which valvular lesion? Your answer would be mitral stenosis. What happened here was a simple event. Tumor plug sound always occurs when the tumor goes and impacts the already open mitral valve. Now listen to my words very carefully. I said this is a diastolic finding. The tumor impacts and already, the word is already, open mitral valve. I have jotted down this statement only to sensitize you to the fact that why was I saying that this is a diastolic heart sound, because they will put up questions like these, all are systolic sounds except. So you will notice that the list will keep on growing, because at the moment maybe the data might look very simple to you, but the point is this is a already open mitral valve, which means the fact that this sound is going to be heard after the opening snap. I repeat my fact once again. You see, I said first the valve will open, then the tumor will come and slam from the top. So first when the valve will open, that is gonna be opening snap, and then the tumor will come and slam from the top. So tumor plop sound is definitely a diastolic finding, but it's gonna occur after the opening snap and not before the opening snap, because before opening snap anyway the valve is closed. This is a low pitch heart sound that can be appreciated best with the help of a bell. Now the clinical question that would come on this topic will usually be describing a young female. Let's look at why she has come to you. She is not aware of the fact that there's a tumor which is developing in her left atria. We very well know that the benign tumor of the heart, atrial myxoma, is the main villain behind genesis of all this problem. And this lady, why she came to me was, she says, doctor, I get tired very soon. Earlier, I could climb the stairs of my house 10 times per day. I could go to college. I could do household chores, routine activities. She said I was fit and fine, but doctor, I don't know. I tend to get tired very soon, and I also started developing breathlessness. Why is she developing breathlessness? Because as the tumor will progressively increase in size, it will cause congestion in the left atria. That congestion in the left atria will be transmitted to the pulmonary veins, and then there would be a pulmonary edema component that is developing. And now she is telling me a very peculiar statement. She is telling me, doctor, that when I sit up, like I am sitting on a chair before you, she says, doctor, when I am sitting up, I feel more breathless, but when I lie down, the breathlessness resolves. And I'm thinking to myself, what's going on? Because traditionally in cardiology, you always read the word orthopnea. Orthopnea basically means that the person has breathlessness on supine position. But this lady told me categorically, no doctor, when I lie supine, I'm okay. It is when I'm sitting up, I'm having a problem. So let's look at the problem here. The basic issue is, let me just increase the size of the tumor so that you can relate to this better. Just imagine this patient sitting on a chair next to you. You see, because of gravity, the tumor will go down and it will block the entry of blood from the mitral valve into the left ventricle. So because of gravity, since the tumor will be causing an obstruction as compared to you and me, therefore there will be more congestion in the lungs of the patient, because pressure will anyway begin to build up in the left atria if you have a physical obstruction present, because this is going to behave like mitral stenosis. So the surprising term that I'm gonna coin, I would say the symptom is surprising, and the term that I'm gonna coin to describe the manifestations and is a very good pickup point in multiple choice questions. In fact, most guys, they say, sir, the moment I read this word, I could narrow down to the fact that he's talking about atrial myxoma, because the clinical stem of the questions can be relatively longish. It could be 3-liner, 4-liner, 5-liner MCQ, and he can go on and on talking about cardiovascular complaints of the patient, but this keyword would help you narrow down to the diagnosis of these patients, and obviously the auscultatory finding would help you. Platypnea is one of the important findings that you will be encountering in a patient of atrial myxoma. Though make no mistake that in the later part of this app, you will see me talking about the liver, and I'll be describing a compensation of cirrhosis, or rather I would say decompensation. First there is compensated cirrhosis, then there's a decompensated cirrhosis. So there's a complication of decompensated cirrhosis that is called as hepatopulmonary syndrome, where again you will see me talking about platypnea. In fact, there's a discussion on hepatorenal and hepatopulmonary syndrome separately in the app. You can listen and check it out subsequently, but this is anyway a word that would make you think in terms of these two possibilities. Now, when I examined this lady, I was very interested in checking her hemoglobin report, because I immediately checked for pallor, because in India, if it's a young woman and she says I get tired very soon, I feel breathless, I'm first thinking it could be simply an anemia component, but then I noticed there was no pallor. Her hemoglobin reports were perfectly fine, and I could hear was a very classical auscultatory finding, that is tumor plop sound. This finding actually may be missed. Why? Because this is a low pitch sound which is heard with the bell. So either if you are not going to auscultate the patient with the bell, you're going to miss it. Second, if the tumor is small, the sound may not be of a substantial intensity, and especially in a busy OPD, like in our government medical college OPDs, you will notice in a small room, 4 doctors are sitting, so many patients, everybody is talking and asking complaints from the patient. So in that noise, in that cacophony, the tumor plop sound may not be heard. But the point is, like, if you auscultate the patient in a quiet room, then this finding definitely can be appreciated. And apart from this tumor plug sound, in fact, lots of time you will notice that tumor plug sound will be heard in a quiet room. What will prompt you to think that this could be a tumor is a presence of a murmur. You see, traditional India, we have rheumatic heart disease contributing to mitral stenosis, but in this patient, there is no history per se of recurrent sore throats or any previous hospitalization due to a heart valve lesion per se. But when I was auscultating this patient, I could hear a murmur, and this murmur will be heard because the tumor will behave like mitral stenosis. It will physically obstruct, and whenever you obstruct, there is turbulence produced. So the murmur that would be heard in these patients would either be a mid or will be a late diastolic murmur. That's anyway a point to be remembered here. And now I would also like to tell you that sometimes if the case is not diagnosed on time and as the tumor continues to increase in size, this tumor will be causing damage to the valve endothelium. You see, the tumor is impacting on the top, right? Every time the blood is getting filled in the heart, the tumor is impacting the surface of the mitral valve from the top. So this impact and I would say repeated impact to the surface of the mitral valve is going to contribute to valve endothelium damage, and the moment there's an endothelial damage, platelets will jump onto that opportunity. So it's no big deal that in these patients there could be a development of transient ischemic attacks. I'll just repeat what I said. I said transient ischemic attack or neurological symptoms can also be given in this question, which are deliberately put up to distract you, because then you will start thinking in terms of maybe a atrial fibrillation, which could be contributing to this problem. But see, the problem here, why the TIA is occurring is not because of atrial fibrillation, though it can occur. The main reason is the tumor is impacting on the valve again and again. So there's a damage to the valve endothelium. The platelets jump onto that opportunity. So there's a platelet plug formation, and because of the movement here, the movement part can cause dislodgement of this platelet plug, and the fragments will keep on going into the systemic circulation. Another explanation I can say is tumor cells itself could be having a dissemination. You see, the tumor is big, so the tumor cells are getting disseminated into systemic circulation. So in the exam, it's a possibility that he might deliberately introduce neurological symptoms in this particular pure cardiology case, just to throw you off the track. But you need to keep the focus with a diastolic finding, a tumor plug sound, including a murmur, and that would help you think in terms of possibility of a tumor in these patients. Anyway, for confirmation or diagnosis, we'll be doing a transthoracic echocardiography, and then subsequently there's no medical treatment for this person, so we will be referring this patient to the department of cardiothoracic vascular surgery, where a surgical resection of the tumor will be done, and the patient will definitely be much better after it. Now at this point of time, because since I mentioned regarding the tumor present here, so let me just draw another line diagram before you, and I want you to spot the differences that I make in this line diagram with the previous one. You will notice that there will once again be a tumor, but the location of the tumor will be slightly different from what I've done earlier. I am showing a tumor which at the moment is originating from the mitral valve leaflet. Let me just enlarge it for your convenience. What I'm showing at the moment is blood can easily enter into the right side of the heart, but this tumor is again going to cause a physical obstruction. But you can see that the tumor that I've drawn at the moment is not originating from the interatrial septum. It is not a pedunculated tumor. It's more of a sessile tumor. I'll just go back to the previous slide. You can notice the previous tumor had a stalk. It was freely floating in the left atria. When the blood hit the tumor from behind, it just went down, it just moved like a pendulum, and it hit the mitral valve surface from the top while the mitral valve was in the phase of opening or had completely opened. But in this current diagram, you can see that the tumor is originating directly from the heart valves. So what I'm teaching you at the moment is a differential diagnosis for atrial myxoma, right? And you guys can be answering me from the, I would say, pathology knowledge, because even in pathology the name of the tumor is told. You see, I have written the classical term tumor originating from the heart valves per se. It's not originating from the interatrial septum, and I'm very sure by this time you would have guessed it right. The tumor that I'm describing at the moment is papillary elastoma, and why we are discussing is because the treatment in this case will be grossly different. I mean, in this case you will have to replace the mitral valve. You will have to put in a prosthetic valve in these patients. So papillary elastoma, can also be having embolic manifestations. Even here the tumor cells could be going into systemic circulation, so they could be TIA events that could be described in this question, but there will be no classical tumor plop sound present. Yeah, murmur can still be present because anyway there would be turbulence created at the level of the mitral valve. So papillary elastoma again mimics mitral stenosis, but then some of the findings which I highlighted, especially platypnea, is very specific for you to answer in the exam as atrial myxoma. This also gives me opportunity to just squeeze in a couple of baseline information for these MCQs, like what is overall the most common tumor of the heart. So you very well know it's going to be METs. And where are these METs going to come from? So it's going to be one of the nasty lung cancers, that is oat cell cancer of the lung. Another one that could be metastasizing to the heart is breast cancer. And then is malignant melanoma, which won't be far behind. So I have written the data in decreasing order of importance. I mean, every time I'm gonna write anything before you, whether I say it or I don't say it, it's always given in decreasing order of importance. In contrast, if the question is asked as what is the most common primary malignant tumor of the heart, now you guys have the facility of obviously printed notes, so it's not gonna be a surprise for you. But when I take a live class, I usually get very varied answers. So I just putting it up. I mean, can you just comment on this without having a look at your notes? The most common primary malignant tumor of the heart would be answered by you as angiosarcoma. And you see lots of time people answer it as rhabdomyosarcoma. That's an answer in pediatrics. The benign tumor of the heart is what I have already explained to you. That's going to be atrial myxoma. And this is going to be a pedunculated tumor in the left atria behaving like mitral stenosis. And I'll be now describing another disease before you where another heart sound would come up, and that would be what the term that I mentioned initially right at the starting of this video, pericardial shudder, a very flamboyant term, because pericardial shudder is like, you know, a very, I would say, a term right in your face. So let's have a look at how it can be developing. So the background information is that my patient is having tubercular pericarditis. You very well know this is a form of extrapulmonary tuberculosis. The commonest form of extrapulmonary TB in India, however, is going to be cervical lymphadenitis. You see lots of time in your outpatient department, it can happen that you might be sitting very close to patients of TB and they might be coughing on the doctor's face itself. So there's a distinct possibility that there can be a Gons focus developing in the tonsil of this doctor. Normally Gons focus is what we study with respect to lungs, but I'm saying Gons focus is developing in the tonsil, and the lymphatic drainage of the tonsil is jugulodigastric group of lymph nodes. So this chap will develop cervical lymphadenitis. This is the commonest form of extrapulmonary TB, but then another form that I'm discussing at the moment is tubercular pericarditis. Why this patient has come to me is because there would be a serofibrinous exudate outside the heart. This is going to cause inflammation. Inflammation would contribute to irritation of the phrenic nerve, and therefore this person would be having chest pain at rest. Along with this chest pain at rest, the patient will also tell me regarding radiation of the pain. In myocardial infarction, you anyway know that the pain will be pretty, I would say, concentrated in the central part of the chest, but can radiate to the arms also, can radiate to the abdomen also. You would have seen cases where myocardial infarction or angina pain is radiating to the epigastric area, even going down to as low as the level of the umbilicus. But in this case, the pain would be radiating to the left shoulder. So I have a person from a low socioeconomic strata of the society who's today come to me with symptoms suggestive of tuberculosis and even chest pain. The symptoms of tuberculosis are going to be standard presence of low-grade fever, evening rise of temperature, and drenching night sweats also. So when I read all these terms, I was also wondering, am I dealing with something like category B symptoms that I see with the hematological malignancies like Hodgkin's, non-Hodgkin's, and chronic lymphocytic leukemia? The patient also tells me that, doctor, I've been losing weight, though I've been trying to eat more than normal. The cutoff for definition of the word involuntary weight loss is 5% weight loss. Yes, not 10%. It is 5% weight loss over 6 months. 10% is for category B symptoms. Though I have explained this in hematology, but I want to highlight it here only. There's a separate chapter in Harrison for the word involuntary weight loss. The cutoff is 5% or 10 pounds. It's not 10%. 10% is valid for hematological malignancies, which is called as category B symptoms. So this particular patient maybe was even taking treatment for tuberculosis and was maybe non-compliant for compliant with treatment of tuberculosis, and now the disease has caused a extra pulmonary involvement in this patient with the involvement of the heart. So in any patient who's having chest pain, it would be my responsibility to anyway do a workup which would involve performing a ECG, and the ECG of pericarditis is very characteristic in a sense that it would be having is a ST elevation, but this ST elevation will be different from the ST elevation that you will encounter in a case of myocardial infarction. In myocardial infarction, the ST elevation will be having a convexity, and there will also be a concomitant T wave inversion. So in myocardial infarction, we have is what is called as classically a Pardee, P-A-R-D-E-E, a Pardee sign. This is a ST elevation convex in a upward direction. There is also a concomitant T wave inversion that I have here shown before you. But in pericarditis, you will be noticing that the ST elevation of the patient will be concave in an upward direction. I repeat the fact once again, there are two causes of ST elevation that are to be remembered, but in MI it's gonna be very specific leads that are described in acute coronary syndrome. Like in anterior MI, it's gonna be V1 to V4 lead 1 and AVL. If it's gonna be inferior MI, it's gonna be lead 2, 3 AVF. There's a specific pattern in MI which has been discussed separately in the video of acute coronary syndrome. But in pericarditis, the inflammation is gonna be all around the heart, because the inflammation is going to be all around the heart. So he might say ST elevation detected in all the leads except one. Obviously you use a 12 lead ECG, so the only one where you will not be getting a ST elevation, but I would say a mirror image of this would be lead number AVR, because you anyway know from your background knowledge that lead number AVR will have all the findings inverted. I'll say the word ulta in Hindi. That is, in this patient the P wave anyway comes to be inverted. A P wave is negative in AVR anyway. So what I'm gonna get in this chap is, however, a reciprocal finding. That's going to be ST depression, and even T wave will be inverted. In fact, P and T are anyway inverted. It is just that the ST elevation of this patient will be written as ST depression in lead number AVR. The message is in MI only specific overlying leads will be having findings, whereas in the case of pericarditis, the ST elevation will be present in all the leads except for lead number AVR. And in this particular patient of tubercular pericarditis, now the person can deteriorate even further. So let's look at what else can we find. Lots of time you might initially think, when you are hearing this sound that I'm writing, you might think that the diaphragm of your stethoscope has turned loose. You know, lots of time you keep your stethoscope in your lab coat, it gets pressed. So lots of time that rim of the diaphragm tends to get loose, and that can cause a finding which might actually look like a friction rub. But in my case, I have one patient who's genuinely having extrapulmonary TB, and there is nothing malfunctioning with my stethoscope. I'm using a good quality stethoscope. There's nothing loose present there. And what I'm hearing in the chest of this patient is a very peculiar finding called as pericardial friction rub. Now, pericardial friction rub can easily be confused in a multiple choice question with pleural rub. And they have asked this also, how would you differentiate? Because both are scratchy sounds. The difference is based on the fact that pericardial friction rub will be present even when the person will stop breathing. Like you requested your patient, sir, please hold your breath and count up to 10. So person is counting in his mind 1, 2, 3 like this, and while he is holding his breath, the heart is still beating now. And when the heart is beating, the sound would still be produced. So the message is pericardial friction rub is best appreciated not in inspiration, like the options were deep inspiration, deep expiration, mid inspiration, breath holding. The basic concept, as I have explained to you, is that when the person will perform breath holding, lungs are not working but the heart is still beating, so the sound is gonna persist. In contrast, let's also use this opportunity to talk about pleural rub. Pleural rub is best appreciated in the phase of deep inspiration. The best way to differentiate between the two is simply ask the person to stop breathing. If it's gonna be a pleural rub, it will disappear if he will hold his breath. But when it comes to pericardial friction rub, the sound will persist. The heart would still be beating in this person. So I have described at the moment a person who's having tubercular pericarditis, and in these same patients, progressively even a pericardial effusion will develop. In fact, it has already developed. Initially, there is a serofibrinous fluid which might be present in limited amount, but as the disease will progress, if there's a delayed diagnosis, patient is not compliant, maybe he might have been started on antitubercular treatment, he was not regular, and now he was a development of extrapulmonary TB, plus he was maybe having a poor immunity as well. The echocardiography of this patient is revealing presence of pericardial fluid. Normally, the fluid present in the pericardial sac for lubrication purposes is about 20 to 50 ml. In this case, the fluid is increased. So I decided to go in for echocardiographic guided pericardiocentesis. And on the pericardial fluid of this patient, I've also run a CB-NAT test, which would tell me that this person is having, I mean, this would be the most conclusive proof of the fact that, okay, this chap is suffering from extrapulmonary tuberculosis. And I have also started this person now on antitubercular treatment, told him to be compliant. If, I mean, depending on the PSM protocol, since we're talking about extrapulmonary TB, since he was non-compliant, I'm just creating a scenario here before you. If he's non-compliant, I'll just check out whether he's not having any drug resistance also, because lots of time if the person is immunocompromised, he's not taken medicines regularly, there's a possibility of drug resistance. And thankfully CB-NAT also tells us about resistance to rifampicin also. Now I have given ATD to my patient, but still problems would be occurring. So let's look at what's going to happen to this patient subsequently. You can take this as a representation of the myocardium of this particular patient, and outside this is the pericardial space where the tubercular infection was present. My patient has taken treatment. The good news is, once he has taken treatment now, he was regular with his follow-ups with me, and I have been able to successfully treat this guy. How do I know that I've successfully treated? His weight is improving, appetite is coming back, the chest pain component has substantially reduced. So the good news is that my patient or tubercular pericarditis who even developed a tubercular pleural pericardial effusion, maybe a pleural effusion also, this person has now recovered. But the bad news is that after taking the treatment, there might be a development of calcification. You see, whenever tuberculosis heals, even in the lungs, no, even in pulmonary TB, you see that there can be development of calcification. You can see that in red, what I'm trying to represent before you is a thick zone of calcification around the heart of this patient. You can take this to be like, you know, like an eggshell. So one message that I want to give to you at the moment is that constrictive pericarditis, why I'm calling it constrictive, because it will now start limiting the filling of blood in the heart of this person. Constrictive pericarditis is a sequelae of treated tubercular pericarditis. You see, constrictive pericarditis is not a sequelae of untreated. I did everything correct. My patient had extrapulmonary TB. I gave him proper antitubercular treatment. Symptoms of the patient have resolved at the moment, the symptoms of tuberculosis. But because of this subsequent calcification around the heart of this patient, the filling of blood in the heart will be substantially reduced as compared to normal person. So just for representational purposes, let's take this to be the representation of the left ventricular cavity of yours and mine. I've just drawn it, not that I've shown that heart of yours and mine is bigger. I've just tried on a comparative basis to say that there's nothing restraining the heart of yours and mine from outside. And from the current sketch, what I'm trying to show is that every time our heart relaxes for you and me, the amount of blood that is going to come in the heart will be something in the tune of 130 ml. And when this 130 ml blood is going to hit the heart muscle, it's going to cause a little bit of distension of the ventricular cavity, because 130 ml is substantial volume. So in you and me, every time our heart receives blood, the ventricles tend to get distended. There's a slight distension, there's a slight dilation. Now let us compare this with constrictive pericarditis patient. So I'm just going to use a different color to say that, one, the amount of blood that can enter into the ventricular chamber of this person will be lesser as compared to you and me, because there's a limitation there. The heart cannot get dilated, the compliance part is lesser. Or I can say this is a non-compliant ventricle. You will also notice that when this blood will go and hit the muscle, it will try to dilate the muscle but will fail miserably. Why did I say fail miserably? Because there's a surrounding zone of calcification. So the blood is going to hit the wall and then is going to bounce off. And these arrows that I'm drawing in green at the moment are simply highlighting the fact that this event does not happen in you and me. in you and me, when the blood goes into the heart, it's able to distend the muscle because we have a compliant ventricle, whereas in a non-compliant ventricle, the blood is going to hit, bounce off, and this is going to create turbulence. And this turbulence is the one that I was speaking right in the starting of this discussion also. This turbulence is called as pericardial shudder. While I'm writing it, please comment, will it be a systolic phenomenon? Will it be a diastolic phenomenon? Yes, guys, there's a filling of blood in the heart, so it has to be diastolic. This is pericardial shudder. Pericardial shudder is a diastolic phenomenon, and will it occur before the opening snap or after the opening snap? You see, if you take this to be the left ventricle, whether you take it left or right doesn't matter, let's take it to be the left ventricle. In left ventricle, when does filling occur? Only after the opening snap, no? So this heart sound will also be heard after the opening snap. Pericardial shudder is alternatively also written as pericardial knock. It is also written as pericardial shock. This is one of the important findings that we will be getting in person of constrictive pericarditis. So constrictive pericarditis is discussed even separately more in detail as we will scroll down in the videos. But at the moment, my main objective was to sensitize you to the fact that they're gonna give you a list of systolic versus diastolic heart sounds. And at the moment, two that I have been able to imprint in your brain would be one, tumor plop sound again after the opening snap, and then is going to be pericardial shudder, which is having other synonymous names like pericardial knock or pericardial shock. In fact, most examiners, when they ask about this topic, they use the word pericardial shock to cause a bit of dilemma in a student's mind that it is some kind of a shock that we're talking about. Obviously, I mean, this is a loud sound, so that's why we are gonna discuss about this auscultatory finding. So let's just summarize this entire information in a single slide now. I would suggest you, though you have printed notes, to draw this line diagram with me at this moment. You see, I told you that after S1, you're gonna be having a ejection click. Then there's gonna be a second heart sound, which is gonna be followed by an opening snap. Then we're gonna be having a third heart sound, ventricular gallop. Then we have fourth heart sound, which is heard right before S1. In fact, the question asked was which heart sound is heard right before systole. He wanted to see that, do you know what is systole, S1 and S2? If you know systole is starting with S1, what is present right before S1? It's gonna be the fourth heart sound. So I'll just jot it down here. The language of the question was, which of the following is a pre-systolic heart sound? The answer is fourth heart sound, though it is heard in patients of, let me say, hypertension, but in the exam, he just wants to see the awareness of whether you know the sequence per se or not. Now, additional information that I want to add to this diagram is like this, and use a different color pen and remember it. What I'm drawing at the moment is technically called as mid-systolic clicks. Please do not confuse them with ejection clicks. Ejection clicks is opening of aortic and pulmonic valve, but mid-systolic click is what you're gonna be hearing with mitral valve prolapse. There's a separate animation on the same and also a routine video. So when you will listen to the animation component of the main video, this will make more sense to you. But at the moment, what I can say is that in mitral valve prolapse, because the valve is going up higher than normal, so the chordae tendineae which is present below 8, that chordae tendineae will be stretched like a rubber band, and there will be vibrations because the valve is going higher than normal. So the chordae tendineae is stretched more than normal. The vibrations which are set up result in mid-systolic click or clicks because there is multiple chordae tendineae present. So one after the other, they're getting stretched more than normal. I also today taught you regarding a finding which would be heard due to a tumor impacting the opening mitral valve. So the red arrow that I've drawn at the moment is representation for tumor plop sound, which was discussed with atrial myxoma, which happens to be the commonest benign tumor of the heart. I also explained to you today that they would be finding where the mitral valve will open, blood will go in the heart into the muscle. It will go and hit the muscle in the ventricular cavity and then bounce off. The finding that I'm talking about at the moment usually occurs at almost the same time as S3, because rapid ventricular filling is the time when third heart sound is present. And the diagram that I showed before you, this one, is also representing rapid ventricular filling. The blood hits the muscle and bounces off. So I have shown a abnormal finding by the name of pericardial shudder coinciding with S3. But clinically speaking, if he says, how would you differentiate the two, then it is very straightforward, because S3 is a low pitch heart sound. Remember, I told you low pitch heart sounds are only gonna be 3. That's gonna be third heart sound, fourth heart sound, and a tumor plop heart sound. So pericardial shudder and S3 can definitely be differentiated. This would be a finding of, I've used a short form, constrictive pericarditis. And in fact, I can just highlight this data once again before you. I'm deliberately now making a color change here to say that this would help you remember the information relatively better. Tumor plop sound occurs almost at the same time as the opening snap. I said almost at the same time, but first will always be opening snap. You can see why I have drawn a, I would say, a ink change here is mainly to sensitize you to the initial information of 3 low pitch heart sounds, and then a murmur also, mitral stenosis aspect was discussed. If you can draw this by yourself under, let me say, 1 minute, because in the exam he is definitely going to say what is going to occur before or after, or he can say all are diastolic, because diastole is more crowded. The question can be all are diastolic heart sounds. You can see in fact there are multiple abnormalities that I've highlighted: a tumor plop, pericardial shudder, S3, S4. So he will say all are diastolic heart sounds except, and your answer is very simple and straightforward, mid systolic click. Why? Because it is written systole, no? So though there are a lot of hacks to solve these questions, but I think that if you develop capability to draw this particular line diagram that I've drawn right towards the end, then I think you would be much more comfortable solving questions. And towards the end of this video, I just want to say, guys, that knowledge is power. Remember this word I'm going to say multiple times in the subsequent videos also. But knowledge makes you feel enthusiastic to go to college. Knowledge is something that makes you feel more confident when you wake up. So keep on doing 1 to 2 topics every day from the app. Since you have made an effort to come and listen to me and purchase a subscription, so make the money count, make the time count. I mean, money obviously is secondary, more important is time, because time never comes back. So I would request you to just do these videos on a loop and get over with cardiology, because people have a morbid fear of cardiology. That is what I have seen. But with regular practice, you definitely will keep on adding mental strength to your capacity. And as you build up this mental stamina, your performance in multiple choice questions will also keep on increasing. So keep the pressure on, guys. Keep learning. Thank you so much for your patience and hearing me out.